Allô, allô. Bonsoir tout le monde, bonsoir. Bonsoir tout le monde. Ça marche? S'il vous plaît, s'il vous plaît. Hello. Good evening everyone. If we could start. Interpretation services for French. If you need French, just please follow Martina. For those who need the interpretation gear, please follow Martina. Thank you.
Everything went well? Yeah, well, yeah. This is good.
Shall wait till you all arrive. Yes, that's it. John, you're here, yeah. Sally, you're here, next to me. And Rajiv, you're there. Beautifully choreographed. They all sit down together, yeah. You're comfortable, Lois, you okay? Yeah.
Now, good evening, honorable ladies and gentlemen, guests, colleagues, friends. I must say I'm impressed. One of the reasons why I was a little bit apprehensive about moving to Geneva was honestly that when many years ago I moved from the Foreign Office in Bern to Basel, I noticed that against expectations actually in Basel they worked less than in Bern. Because normally before a public holiday such as Ascension Day, we stopped work at noon on Wednesday and we came back at the earliest Monday morning. Now in Geneva, of course, in the city of Jean Calvin, you also work on Ascension Day. But if you see me smiling nonetheless, it has a simple reason. Some of you have been in the city earlier this afternoon. You saw some soccer hooligans from the Valais, Sédunois, and from Basel. And I expected, being from Basel, as usual, when Sion plays in a cup final, they always win, 13 times in a row. They were beaten 3-0 by Basel today. Therefore, too bad for my colleagues from the Valais. I'm very pleased to welcome you here by IFPMA. My name is Thomas Kearney. I'm the new Director General of IFPMA since February 1. I've come here and I'm interested with a special interest in the topic about immunization and about actually age, because I'm of a certain age, as you may have seen when you look at my the loss of hair. It is with great pleasure that we are convening here, and it's the third time actually that IFPMA during this 70th World Health Assembly welcomes to a special event. We talked about Access Accelerated earlier this afternoon, and I'm so pleased that so many have come to this event. Tonight's event is very important because when you look at the late Hans Rosling, he once said, health cannot be bought at the supermarket. You have to invest in health. You have to get kids into schooling. You have to train health staff, and you have to educate the population. Because investing in health is not just about spending on medicines or on medical fees. It's investing in health in terms of NCD prevention. It is actually investing in making people aware that if they be healthy, be mobile, they may need fewer drugs. Maybe surprising from the head of the Global Pharmaceutical Industry Association, but it's a matter of fact. And I think looking at the scarcity of resources, looking at everybody's concern about sustainability of funding, I think it's something which we are well advised to follow. But with life expectancy rising around the world, proportion of the world's population of above 60, I'm part of that, will nearly double from 12% to 22% between 2015 and 2050, not just in Europe, but in many other countries. And when you look at how long it took, for instance, in France, France had almost 150 years. Countries such as Brazil, China, and India will have slightly more than 20 years to see that increase. And also, when you look at Japan, I was recently at a conference on funding longevity organized by University in Palo Alto, and we had a senior official from the Ministry of Finance talking to us. In Japan, it's not just a question of the share of aging people. 7 million population. Japan in 2060, and this is a pretty safe bet because the country doesn't have much immigration. I think birth rate, you know what will happen. Japan will have 80 million people in 2060, 47 million fewer than now, but a lot of those just above 60, but above 80. And actually to give you an anecdote about this. When I was in Japan touring for a hiking, I read that in Japan until a couple of years ago, somebody who turned 100 did not just get a visit of some dignitary, they also got a silver sake cup. No longer. Too many of them. It's now tin. Too bad. But it's a sign of changing times. We are gathered tonight to discuss changing trends and to discuss something. When I look at the debate on aging, I often see a debate about aging as a burden on societies, as something pretty depressing in terms of, oh gosh, how do we look after all those aging people? How do we equip the nursing homes with healthcare workers? What is it a burden, not just on health spending, but actually on pension spending? Now, one factor in terms of investing in health is that healthy aging also means extending productive life years. Unless something dramatic happens, I will retire way after the official retirement age in Switzerland. And I think many other people will do the same, because if you're healthy, if you're lucky, you want to work beyond official retirement age. And actually societies need people to be willing to work beyond traditional retirement age. Now, I will not go on for much longer because we have a distinguished panel of experts, and I will hand over shortly to Zainab, because she will guide us through the discussion, and she will introduce our distinguished panelist of experts. Now, Zainab Badawi is a highly regarded and award-winning broadcaster from the UK. I'm glad that I haven't appeared on her program yet, which is called Hard Talk, because that's something where you normally are torn apart because you are price gouging or you are alleged of price gouging or whatever. You're seen as being the bad guys. Now, I have to admit, I do believe in Harry Truman's word, if you can't stand the heat, don't get near the kitchen. And actually, it's quite fun to be in the kitchen once in a while. I do want to hand over to Zainab. I do encourage you, please engage in a hopefully animated debate after our panelists gave the introduction. Also, I do encourage you, please stay with us afterwards for the reception. If you do need translation, si quelqu'un a besoin d'une traduction française, il y a de l'équipement dehors. Sinon, on va dire à nos gentils interprètes que peut-être ils peuvent réjouir le jour d'Ascension un peu avant l'heure, parce que lorsque je regarde dans la salle, I haven't seen. If there's somebody, please pick up your headgears. S'il vous plaît, prenez, parce qu'on a l'infrastructure là-bas, and we are well equipped. And with this, I hand over to Zainab. Thank you.
Thank you very much indeed, Thomas. Thank you very much. Nobody's wearing headphones, so I think everybody is going to be following the English, because the panel are all going to be speaking in English. So I'm Zainab Badawi. It's my great pleasure to be moderating this very interesting discussion about an aspect of elderly, the life of the elderly. Immunization is a very, very fundamental part in many people's opinions when it comes to looking after the older people and making sure that they can lead productive lives and healthy lives. And so we want to look at the challenges and also look at what the implications might be for policies with our panel here. So they're going to make just a few introductory remarks, and then we'll have a bit of a discussion, but also involve you. And by the way, do smile, because you may be on camera, because this is being live webcast on the IFPMA's website. So you'll be able to know that you're going to be talking to an audience far greater than the people we have assembled here. I'll start off with you, Dr. John Beard. So John is the Director of Aging and vaccinations, life course of vaccinations.
Vaccinations is a much bigger department.
It is, right, yes. Well, your life course. But it is interesting, life course, you could have wanted to add another word to it. But anyway, you are a physician, and you're also somebody who's had a great deal of experience, because you've actually worked as a doctor yourself in South Africa, in the UK, and also in Australia, where you were working with a rural Aboriginal community. And so you've seen what it's like, actually working within communities, but also at the administrative level. But also, interesting enough, you led on public health during the Sydney Olympics in 2000. You didn't compete in it too, did you?
No, no way.
You look like you might have. So as far as the WHO is concerned, how do you see the whole picture of when we're talking about immunization? Is it yet a kind of integral part of your approach when you're looking across the world when it comes to the elderly?
I think traditionally immunisation is focused on infants. And more recently, we've started to think about adolescents. But I think this meeting is a reflection of the fact that we're now starting to think about the whole of the life course. I think that's very important. One of the things that happen as you age, you don't just lose hair, but your immune system actually starts to decline. And it's inevitable. And that has two consequences. The first is you're more susceptible to infectious disease. And the second is that the interventions we might use, for example, vaccinations, can be more difficult because we can't stimulate the immune response that you need. And that's particularly important because the world is rapidly aging, populations around the world. And while that transition started in high-income countries, these days it's occurring most rapidly in low and middle income countries. So places like China and Iran will soon have population structures similar to Japan. And while it's non-communicable diseases that overwhelmingly are the burden of disease for older people wherever you live, in low and middle income countries, it's still communicable diseases that play a very significant role. So we're thinking now about what we can do to change that, I think, is absolutely crucial.
So focusing on the lower income, middle income countries. Baroness Sally Greengross, you are somebody who's dedicated a great deal of your professional life looking at all aspects of lives of older people. You quarter of a century you're involved with age concern, and you are an independent peer in the British House of Lords, where you also chair half a dozen all-party parliamentary groups on issues. One of them is on dementia, another is on corporate social responsibility, and also aspects of the ageing population. When we're looking at this kind of topic, it's very important, isn't it, to try to integrate the community into the debate. You represented older people, you're an advocate for them, that they've got to be part of this debate.
Absolutely. You don't do things to people, whatever their age. You do things with people, and you have to make sure that the people want to do the things you're advocating. What we want, all of us, I think, whatever our age, is to be able to celebrate the aging of the populations, wherever we live, in a very advanced society or one that's not so technologically and technically advanced, where the problems may be slightly different. But we do know one thing, that if you get an illness when you're older, then it leads to complications which narrow your life, and it is very hard to continue to live well. So the most important thing is try to avoid them, because they're complex. When you're older, very often it's a whole complex range of diseases that get you in one go. So what we have to do is to prevent them, and our systems aren't really set up for this. And one really good way of doing that is to immunize people. We think it's just for kids, but of course it isn't. And if you don't immunize older people, then the effects are much worse than they are very often for younger people. And it's cheap and it's easy, but people don't think about it. Employers have got to think about it. Why don't they think about their staff as they get older? Immunize them. Why don't we get local chemist shops, pharmacies involved in this? They can do it, and it's cheaper and it's easier than having to go to your doctor. And why don't we publicize the benefits of immunization? They are huge. They avoid the complexities that weaken you sometimes over years as you get older. And we just have to change attitudes. It's not just when you're a baby or when you want to go on holiday if you can afford to. It's for everybody. Why don't we say to everybody at 50, just have all those diseases we can protect you from. Do it. It's cheaper sometimes than getting a cup of coffee.
So that's like creating a new social norm.
Exactly.
And I should say that you're co-president of the International Longevity Centre, but you're also executive director of the Longevity Centre UK, and you have these kind of debates. We'll come back to you in a moment to expand on what you've been saying, but let's have some introductory remarks from you. Lois Brevoort-Dum, you are the from the Johns Hopkins University, where you are at the International Vaccine Access Centre, where you're Director of Policy Advocacy and Communications. And you've worked a lot in lower and middle income countries on a global scale, but also in country, in places like Nigeria, India, and Pakistan. So you've got both the kind of world outlook as well as in country. Where do you stand on this issue?
So I was very happy to hear Sally's remarks. We were talking earlier about really making action happen. And I think it's just so important. There is a lot of evidence out there. We as researchers often look at the evidence. We always want more evidence to move forward. And I think for adult immunization, there is a good starting point right now. We're at a point where we're talking about the Strategic Development Goals and universal health care. So that provides an opportunity to talk about the importance of immunization being such a critical element of being able to achieve goals of healthy aging. And there's so many reasons to do that. Does that mean that we have all the answers right now and that we can just go out and say we should start immunizing every adult tomorrow? No. I actually wish that was the case. But there is a process that needs to happen, but I think we can push that process forward in a different way. We study what it takes to make global initiatives move forward, what it takes to make them take hold, and it's getting that evidence base out there and a champion behind it to move things forward and have the conversation. And I think right now is the time to have a conversation about the different value of immunization. One that's not just about saving lives, one that's about ensuring healthy living, that you're ensuring a economic well-being for not only the individual, but also countries and moving forward, as well as a lot of other issues that could be addressed through immunization.
Thank you. Rajiv Venkaya, you are president of the Global Vaccine Business Unit at Takeda Pharmaceuticals. But you've also had a spell with the Bill and Melinda Gates Foundation and also in the White House, where you were an independent advisor to President Bush. You also worked in Homeland Security and was a consultant there, and not been invited to work in the Trump White House, have you?
We need to stick on the topic.
Oh, okay, we need to stick on the topic, right. And so when we look at the industry perspective, do you feel that immunization, vaccination is a very useful tool in the arsenal when it comes to looking at the needs of older people?
I do, and I think I'll reflect my perspective from the different roles that you mentioned, and thank you for remembering all of that. That's a lot of detail. The reality is that we have a miracle in our hands in vaccines, a miracle that has been described in terms of the lives saved and disability years averted in children. And vaccines are really responsible for the bulk of reduction in under 5 mortality since 1960 to today. We're now around 6 million deaths under the age of 5 that are preventable. Still too high, but about a third of what it was in 1960. So vaccines are a miracle. What we don't talk about as much is the fact that vaccines are also highly cost effective when used in the elderly. Just to give you one data point, influenza vaccination in the United States, $1 invested in that will avert about $60 US in healthcare expenditures. So this is a very powerful tool in the elderly as well. Why does this matter today, though? We have all seen the debates that are going on in countries around the globe around healthcare expenditures. We know that the global community does not feel that it has enough resources to support all of the healthcare needs of the population today. Well, to build upon what Thomas said, Today, the average age around the world is 70 years, average life expectancy. By the middle of the century, we expect that to be 77, and by the end of the century, about 83. So we're seeing this massive demographic shift, and on top of that, we're seeing this iceberg of non-communicable diseases that is emerging not just in developed countries, but in all countries. And so this is going to put tremendous pressure on the healthcare system. Anything we can do to reduce that burden will allow our resources to go further. And what we've shown in vaccines is the simplest way to do that is to give somebody 1 or 2 doses of vaccines at a vulnerable moment in their life, and you can protect them for years to come. And so I'm completely sold on the vaccine case, and I do think it's something that we ought to be looking at much more closely in the elderly.
So, John, looking at all the competing demands for healthcare, for international institutions, and also for governments, how easy is it to make the case for vaccinations, immunization, be it flu jab, be it tetanus, diphtheria, pneumonia, or whatever, for older people?
Okay, well, I think first of all, it's important not to set up a them and us scenario. So it's not youth versus old. I think the goal that we all have and that the Sustainable Development Goals really espouse is that we want to create fair, equitable and cohesive societies. And that means you need to look after everybody. It means we have to try to enable health for all at all ages, which is the Sustainable Development Goal 3. And part of that is thinking about where you invest at different stages in life, where you can have significant impact. But it's not saying investing here is more important than investing there. Let me give you an example why. If you're an older person, you develop influenza, you're bedbound, it can set you back and lead you to a position where you become very frail. You then require long-term care. That requires, in most poor countries, families to look after the older person, where previously they may have been independent or bringing in resources. Families actually means women. It means women who can't go to work or girls who can't go to school. So the impact of not investing in older age actually impacts on all generations. So I think we've got to move away from the them and us to thinking about the life course and how we get the balance right.
But when you think about it, public campaigns and, raising awareness, everybody knows about, you've had a baby, you've got to have your, MMR, and the importance of childhood vaccines, and, UNICEF run their very visible programs and often ask, for people to support their campaigns and so on. You don't really get that when it comes to older people. And, in the UK, actually, is a bit of an exception. Flu jab, that's very visible as a campaign, isn't it? And the take-up is quite high relatively in the UK,
but it's not
75%.
Yeah, it's not high enough still.
Right.
And the return is about, we invest 1 and the return is 4. So it really is a good investment. The flu jab is just 1. But if you're older and you're already a bit frail and you get flu, it leads to all sorts of complications, which are then terrible for you and awful for your family and the community, because everybody gets involved. And I think it's this almost contagion of an illness, not through just catching it, but the effect on other people that's important.
Sure, but if the arguments are so persuasive and cogent and, underscored by economics, €1 spent, I think it was the Dutch study, €1 spent on immunisation of older people results in something like €3 of government revenue. Why do you think that we don't have the same kind of emphasis on vaccinations for older people as we do for younger people, for children?
I'm afraid, really, that some of this is a form of discrimination. We're not conscious of it. We're not aware that we're discriminating. But there is a different attitude towards older people than there is to younger people. And in a way, we've got to stop thinking like that, because if you're young or you're old, it's not just you who is affected. You can say, well, they're nearly dead anyway, so what? No, it's that person and that person's feelings and their life, but it's all the other people who are involved. You can't think of one group in society. You have to think of the effect on their family, and that's just what you've said, on the women in the family, on the girls who want to go to school, on everybody who's involved, on the level of income of that family so that they can live better, particularly in developing countries.
Lois, you work in advocacy and communications, so how do you go about essentially trying to create a new social norm so that people expect older people to have immunizations?
Well, there's several things. First is creating the value of vaccines, which again, we need to to move away from solely talking about preventing death to the other benefits that vaccines provide. The idea that you can go to work, and older adults are, as John said earlier, they're working to older ages. Older adults are also watching grandchildren, enabling others to do their job and go to work and lead a more productive life. Preventing disease also has implications on antimicrobial resistance and some of the broader issues that we're talking about and starting to worry about. And the big thing is also thinking about catastrophic expenditures. In a lot of countries, people are healthy and have a fortunate situation that they can access health care. But in many of the countries that we're working in, any type of illness can just devastate a family, and not only the family, but the community. And one of the things that's happening is when we're doing our economic studies, we're talking about a very, very narrow definition. And I think we also talk about evidence in probably too technical of a way. We really need to be bringing in other types of stakeholders that have an understanding. And one of the things that I really love about this panel is that it's not just the immunization community talking about vaccines. It's starting to bring in people with different perspectives, the educators, the employers, the people that are from religious communities and other places, because the more people that are valuing vaccines in a way to keep them healthy and have a good lifestyle, I think that's the way you start to move the needle.
I mean, can industry bring any innovative thinking in this regard, Rajiv?
I think that there have been certainly not as many vaccines developed for the elderly to date, although that's changing quickly, particularly with the emergence of antimicrobial resistance. And here I think industry can do a lot to make the necessary investments to develop vaccines against, for example, Staph aureus, which is an increasing problem and a resistance problem in hospitals. And if you are an elderly person who has Staph aureus in the hospital, that is a very big problem that is going to likely keep you hospitalized for a long time and place many others at risk. So I do think the innovation side of this should not be forgotten. We primarily talk about influenza, pneumococcal vaccine, and the zoster vaccine, as well as the old-fashioned vaccines for diphtheria, tetanus, pertussis. But we, I think, need to focus on additional vaccines in light of the new AMR threat, antimicrobial resistance threat. The other point that I would make is just on a human level, we as a community that cares about health often, always prioritize vulnerable populations. And those vulnerable populations are, of course, children, pregnant women, and the elderly. This is a vulnerable population like the others, and they should be afforded the protections that we provide to those other populations where appropriate. The final point I'd make is that any of you who have had a close family member who has been, I'm an ICU physician by training, if you've ever seen a loved one in the ICU on a ventilator, you know how devastating pneumonia can be. Just think, in every one of those instances, if we could have prevented that intubation and ICU and mechanical ventilation stay with a single shot, an immunization, you'd take that deal in a second for your loved one, or frankly for anybody else's loved one. So the human element, I think, is something that we need to keep in mind as well.
Just add one point to that, and I think we do a disservice sometimes that we don't tell enough stories, and we don't tell people about the experiences of what it really meant. We talk about populations in terms of numbers, and the more and more that you can get down to a personal experience, because everybody is going to immunize for a different reason, and being able to just connect to what is important to that particular person and get them to think about, what if this was your family member? sometimes immunization, because it's something that's across a broad population, people think this is never going to happen to me. But guess what? It probably has happened to you or some family member, and just changing the mindset and the conversation about thinking about the individual can also make a big difference.
Can I also say, Zainab, I think that one of the barriers to the innovation that Rajiv is talking about is the ageism that Sally raised, because I think we tend systematically to undervalue older people. And so, for example, and sometimes it surprises people the contributions that older people make. For example, in Kenya, the average age of a smallholder farmer is 60. That means older people are actually crucial for food security in Africa, but people don't think like that.
And a 60-year-old female at that.
Yeah, probably. And also, we tend to think that by undervaluing older people, we tend to think of them as a burden or not worth investing in. And so the focus, and this is often the focus of political debate in the rich world, is on saving costs. It's much better to think of expenditures on older populations as an investment, and the return can be in enabling older people to participate and contribute and be part of your family. And because we undervalue them and because we're looking at saving costs, we don't think of the innovations that might be there. And it was great to hear Rajiv talking about Staph aureus. I mean, there's a whole range of things we could be thinking about that vaccines might be very effective for, but we're not even starting to ask the questions. We don't even know, for example, what are the really heavy burdens of communicable disease in older age? What should we be targeting? What might be effective? And even more, I said at the beginning that we have this inevitable decline of our immune system. Maybe there's something we can do about that. But we have to be thinking, we have to be starting from the point that we actually value older people, we want to enable their contributions, and we need to think innovatively about how to create that.
And is it the same whether you're looking at, Europe, North America, lower-income countries? They're going to be different sets of challenges.
Very different. And in fact, to give you an example, the changes in the immune system don't just affect your vulnerability to communicable diseases. If your immune system is worn out as you age, and this often happens in low-income countries, so if you have a chronic underlying condition like cytomegalovirus, your immune system can be worn out, and perversely it then actually initiates an inflammatory response, which can cause heart disease, all sorts of other complications in later life, which we don't really think about when we think about vaccine-preventable diseases. So all of this ties together, and what it means is that poor countries, where people have more exposures to infectious diseases, they're also the countries where people actually age more rapidly. And we need to be thinking about the role of vaccine in changing all of that.
Yeah, sure.
One of the interesting parallels here is from childhood vaccination and the inequities associated with who gets the innovation first or who has historically, and that's changing now. Think about rotavirus vaccine. Rotavirus vaccine prevents childhood diarrhea and is responsible for a massive reduction in under 5 deaths. But those deaths are not happening in developed countries like the US or European nations or Japan. Those deaths are almost all happening in children in resource-poor environments because there isn't a working health system in many of these places that can handle diarrheal disease and rehydration, some of the most basic support that you should be able to provide. It's not there, and so children die. The exact same the exact same situation exists in the elderly. If you are an elderly individual and you don't get an immunization against, say, flu or pneumococcus, and you are infected with that virus or bacteria, and you become very sick and antibiotics don't work, if it's pneumococcal pneumonia, there are likely to not be resources like an intensive care unit or like a ventilator. And so what will happen? The same thing that happens with children in resource-poor environments. They don't survive. And so I think this equity issue is another, vaccines are, I won't call them an equalizer, but they're a tremendous tool to improve equity because the benefit of the vaccine stays with the person if you get to them just once or twice.
Sally, you wanted to say something?
Well, I was just going to come back to fully industrialized countries, and because everything, I think the priority is exactly what John was saying about what happens in less industrialized countries. But here, and in the United States, for example, or in my country, if you've got an older worker who is actually infected with flu, which turns into something much worse, you are losing a very valuable person. And those multiplications of those people are a huge hit to our economy. And I think we all know that if somebody of 60 says to an employer, I'll give you 5 years of work, they will. But if they're actually caught out by some infectious disease, then it will get worse. But you've lost a very valuable member of your staff. And the cost to you, the cost to your business is huge, and possibly even huger than it would be if this was a younger person, because here's your very experienced leader who was going to go on for another 10 or 15 or even more years. And the cost is enormous. So it's not just saying older people are vulnerable, we must look after them. It's saying these are valuable people in our society as individuals, as family members, as carers and caregivers, but also as employers and employees. They're a huge, valuable tool in our economy. And in less industrialized countries, they don't think of retiring anyway. They're part of the main economy.
Sure.
And we forget that.
So when we're talking about providing, helping older people to lead more productive and healthier lives, I mean, what do older people themselves say as a community when we're looking at immunization? Are they preoccupied with this? I mean, you know, because you said it's got to be something you don't do for them. I mean, but is there an awareness that
There isn't.
There isn't amongst the older
nearly enough,
community?
No. Older people will look after their grandchildren and worry about them. Older people don't think about themselves on the whole. Of course, there are exceptions. But I think there's an enormous job for us all to do to make people aware, not just of the need to have immunization, but to think of the complexities that happen if you're older when you get an infectious disease, because it leads to the sort of complications that can affect your quality of life, not necessarily kill you, just make the rest of your life very unpleasant.
Do you think if they demanded this more, if you
Yes.
managed to get a kind of pressure group,
We
and
must bring older people in to demand this sort of thing. But it's not just older people. We're talking about the second half of life here. We're talking about a massive movement in all our societies. And we need industry, employers, the PR industry, the advertising industry, people to come together and realize this is absolutely necessary and essential. We must keep people healthier. Our health systems can't cope
Sure.
otherwise. And instead of welcoming the ageing of society, we begin to be frightened of it.
We'll go to the floor, but I just want to ask you very quickly, John. I mean, looking at immunisation for older people, what exactly are we talking about? For instance, you know, as we said, as children, you get your MMRs. If you go on holiday, people are told you've got to have tetanus, diphtheria, cholera, and all the rest of it. But, you know, what do older people need in terms of immunisation as they get older?
We still need to maintain some of that.
Even if you don't travel?
Yes, so
If you live in
for
Europe.
example, tetanus.
Yeah.
But the big issues in older age at the moment are influenza, pneumococcal disease, and shingles, which it can be a very debilitating condition and is very common in older age, and where there is now a very effective vaccine. But I think the challenge we have, and we have to be realistic here, is there have been limitations to the vaccines that are currently available for older people, or the vaccines that are available when they're applied to older people. And it's been really heartening to see over the last couple of years there's been a focus on how we can remedy that through adding adjuvants to the vaccine, through giving higher doses, I think, but that requires these innovative ideas and looking at this as a valuable population that we really need to do something about.
Can I also add one other thing? When we think about innovation, it's not just technologies. I think it's also innovation and communication and how you get that message across, thinking about the various touch points that people have. And it may not be, you know, if somebody tells me to go and get my vaccine, it may fall on deaf ears in all seriousness. But if my children are telling me this, if my grandchildren are telling me this, or my child that's going to get her infant immunization is thinking about this at the time and delivering those messages back and talking about the impact not only on me, but on her child, for example, that can make a difference. And sometimes I think we need to be more creative about the arguments that we use, because people won't always accept that they'll do it for themselves, but when you're doing it for others, it can change the scenario.
Can I also add, just before we go to the floor, I think it's a very important point. Having the vaccines is one thing, having access to them is another thing entirely. And when we look at older populations, what we see is an incredible variety of experience. So some people in their 80s retain very robust health, whereas others in their 60s require considerable care and support. That distribution is not by chance, it's not random. The people at the top more than likely have experienced cumulative advantage across their lives. The people at the bottom have experienced the opposite, the cumulative impact of disadvantage. And that means the people with the poorest health are often the ones with the least resources to draw on to meet their health needs. And so I think that also comes down to the utilisation of services and how we target these interventions, because we need to make sure that we're trying to address those inequities rather than just simply try and raise the average. We need to pay particular attention to those people at the bottom and the access to the sort of things we're talking to that they need.
As a first step. All right, thank you. There are microphones, I think, or a couple of microphones. Yeah. Can I see hands? Yeah, there's one there, one there. We'll take a couple at a time, 2 or 3. If you could stand and introduce yourself and your organisation if relevant, thank you. Gentleman there with the... Yep, stand. Is there just one microphone? Yeah.
Okay, I'm Martin Frieda. I'm the coordinator of the Initiative of Vaccine Research at WHO. So within WHO, I lead our activities on research on vaccines. So first of all, to IFPMA, thank you very much for this critical activity. We recognize this is a critical, important event. Now, an activity. So my question is both to John and to Rajiv. John, you pointed out that immunological age does not match chronological age. And since this is WHA week, this is the week that we try and get recommendations. How are we going to come up with recommendations which are applicable globally when we've got such a huge difference between the life expectancy in Japan and rural India? How are we going to come up with something which says the vaccine should be given at a certain age? And I posit that giving a vaccine to a 70-year-old is like recommending a 70-year-old to start saving for their retirement. It's too late. We've got to start giving earlier. But earlier, what age and in which country?
Thank you. Microphone to the chap there behind you. Yep.
Hi, my name is Matt Roberts. I'm part of Universities Allied for Essential Medicines. So you rightly pointed out the issue of increased healthcare costs. I think several members of the panel pointed that out. And of course, this is an issue that is no longer just affecting lower income countries, but also higher income countries. Dr. Venkaya pointed out that vaccines are one way of addressing this, but of course it's not the only way. There's been a lot of discussion and several examples of the concept of delinkage, that is, delinking the price of medicines from the cost of research and development. And this can be achieved through things like push and pull mechanisms, one example being milestone prizes for innovation. And these represent effective ways of decreasing the cost of healthcare and therefore increasing the quality of healthcare that's available to people throughout the entirety of their life course. So I'd be quite interested in hearing the opinions of all of the panel on the idea of delinkage as a way of improving healthcare for all. Thank you.
Okay. Yeah. Should we take those for the time being? That particular point of delinkage of healthcare, I think that was directed at you, Rajiv, and then we'll come to you, John, on the what age. Can you make recommendations that work for India and America or whatever? Yeah.
Yeah, I think that this delinkage of investment in R&D from the overall cost of the vaccine is an approach that has been proven actually in several instances, and we've seen funders like the Gates Foundation and certain governments fund the R&D at a company to develop a vaccine, drug, diagnostic, or other intervention for a high priority purpose. So the examples I'm most familiar with are in biodefense and in emerging infectious diseases. And we've recently seen the launch of CEPI, which is focused on this. CEPI is a Coalition for Epidemic Preparedness Innovations. This I think is effective in those areas where you need the industry to mobilize and develop something very quickly. I think it's an interesting thought to see whether we would want to, or whether anybody would fund that kind of activity for what we're talking about here. I think if it's linked to a high priority threat, like antimicrobial resistance, that may be possible. You may be able to find funders interested in doing that. In the absence to that, I'm not sure that you're going to find a lot of interest amongst the funders, but it could certainly be explored.
And do you have any on the age, what works in India may not work in Japan and vice versa?
Well, so the way with vaccines, the WHO plays a critical normative role in setting, providing guidance for all countries on how to implement health interventions. But in the case of vaccines, there is also a country-level recommending body that is a National Technical Advisory Group on Immunization that takes, that localizes whatever is coming from the normative bodies. And I think that, I don't have an exact answer to the question, but I think having the liberty in these recommendations to dial them in one direction or another, depending upon local circumstances, is very important so that the local authority doesn't feel like they are constrained in recommending something that may not be appropriate for their population. But then they can look at local circumstances and set the age in this case where they think is appropriate for their
John? And then Norrie, yeah.
Okay. Well, I'll take a slightly different approach. I think we should stop thinking about chronological age and start thinking about the function of and the capacity of the older person. I think traditionally vaccines, we give them in the young at certain ages, but I don't think that's actually applicable. As I said before, chronological age is a very bad indicator of your capacity and your ability to do the things that you want to do. I think what would be much better is for us to measure capacity directly and use that as the outcome or use that as perhaps the indicator and also as the outcome of the effectiveness of the interventions we put in place. It's a very different way of thinking about it, and it's not just applicable to vaccines, but it comes down to the very question of what is health, and health is not just the absence of disease. So I could talk for hours on that.
Oh, well, okay, well, you did for a couple of minutes. Yeah, Laurie.
If I can add to that, I love the idea. I think we should be shifting towards capacity. What we do need to figure out in the meantime is how do you define that, and does the provider have the capacity themselves to define capacity? We find that even when you have at-risk recommendations, that those often become very challenging to deliver them to the right people. And particularly in places where the health system is not particularly strong, that becomes an even bigger barrier. I do agree with Rajiv about the role of the National Technical Advisory Groups on immunization, because they do play a very critical factor in not only analyzing the data, but also looking at what is feasible within their context and looking at what are the priorities for particular populations. So some of the work that we do with the technical advisory groups or ministries of health is help them look at a little bit of needs versus feasibility. So you're looking on different axes so that it's not a clear-cut answer, but something that can analyze where do you really want to have the biggest impact and what is it going to take to develop that biggest impact. So that I don't think it really answers your question, and the like SAGE has a very, very tough job ahead because, ideally we'd love to get to the place that John is talking about. I think what's easier right now today is that age approach. So the question is, what is the roadmap to get from an age approach to more of a capacity approach? And that's where I would put the emphasis, is bring people together, and not just the people in immunization.
Sure.
Bring together providers, bring together aging advocates, bring together maybe ethicists and all sorts of people to look at that issue, because I think it's one that's not going away and one that needs to be prioritized.
Thank you. There was a lady with the microphone. Yeah, if you could stand, thank you. Can I see more hands? And then two more there, yeah.
Good evening, my name is Yulia Yurova. I'm from Gavi, the Vaccine Alliance. So I have two brief questions. First is I would like to know your opinion about the biggest challenges and big opportunities to increase coverage of routine immunization in order to achieve equity in health prevention. And second one, currently we see the increased movement of anti-vaccination, anti-vaxxers, as they call themselves, with older leaders like Trump, Kennedy, Andrew Wakefield. Would you see that they would be more supportive of vaccination of aging population?
Right.
Because the
Okay.
link
Well, I don't think anybody can speak for Andrew Wakefield and all the others, but there we go. All right, microphone there.
Hi, Carmel McClelland. I'm just a medical student from London. So I really appreciate you bringing this topic up. As someone who volunteered for 5 years with Age Concern, actually, I really understand this issue. I was just wanting to, hoping you could address some of the concerns possibly brought up by MSF in their Fair Shot campaign, particularly around the price of the pneumococcal vaccine. So they managed to get Pfizer to bring the cost down there. And just if we're thinking of a global and sustainable solution to this very important problem, I'm just wondering what your thoughts are about how we can manage cost in this particular area, or rather price of vaccines in this particular area.
Thank you. And then there was one more hand, I think. This gentleman here.
My name is Raj Kumar. I also work at Gavi, but this is not related to my organizational affiliation. During 1993, World Bank brought out a publication called the DALIs and this thing, the disease control priorities, and that really determined the investments in the global health. Now, if you invest into childhood immunization, you can show the quantitative advantage of saving so many live years and this thing. And you can never challenge it when you try to invest it in an older age. Because in the older age, what matters is the quality of life, not the longevity. Whereas in childhood, it's the longevity which also matters. And I think a few years back, I still remember, I think WHO had an annual day where the theme was add quality to years. So it was not really extending the number of years of survival, but quality. Unfortunately, we do not have any metrics to determine that quality element of life. And just to give a simple example, I think a lot of people become blind because of cataract in the developing countries. A simple operation gives them the vision back. It's not so much that they are extending the life by another 10 or 20 years, but the confidence that comes to them. Unfortunately, we do not have the metrics to really say, how do you compare the quality element vis-a-vis the quantitative element? So I'm not sure what I am asking.
Let's see what, well, we think we'll work it out. Sally, why don't you pick up on that? Should you rename yourself the International Longevity and Quality Centre?
Yes, because what we're measuring is the fact that whether it's intended or not, people's lives are very, very, very much longer. People are surviving. And yes, it's important, and what we're talking about now is that these extra years are of quality. So it's a fact all over the world that longevity is increasing very fast. So the issue for us all is to make those years worth living. So it comes back to what you are really asking about. We can, through vaccination, through immunization, we can make the quality of those extra years much, much better. And we can also help countries who are struggling with paying for care, with knowing how to look after their older population. We can help them because they don't get these dreadful, and they are dreadful. I mean, John, you were just looking really at how terrible some of these illnesses are when you're older. So we start at the other end. We start by the fact that people are living longer, much longer. Let's ensure, but the most cost-effective way I know of doing it, that the diseases we can prevent, we actually do, because we've got enough to cope with the ones that we still, like dementia, we still can't prevent.
Can I just respond to that one
To
too?
this particular one, yes, sure.
Because I totally agree with Sally on this issue of it was add years to life was the slogan. But in fact, the DALYs that you mentioned, which were used in around 2000 to say that we really have to invest in children. So DALYs really weight disease in an ageist way so that children, if you have the same disease, you get many times the weighting than you do if you're an older person. In 2000, it showed that there were more DALYs being lost in children than at other ages. Today, that's no longer the case. Today, it's actually pretty equivalent across the life course. By 2030, it'll be really heavily weighted the exact opposite. So even using the data that was used to justify investment in children, if you're going to be consistent, you actually should be investing in older age. And I think that, so there's a paper that came out just a couple of weeks ago where all this was fully sort of evidence-based. I think we just need to think change the way we think.
Laurie, do you want to pick up the question? Well, there were a couple. The one about how do you get the vaccine deniers on board, but you may not wish to answer that. I don't know. But the part of the other question, I think, if I understood it correctly, was that how do you use immunisation programmes to close the gap between countries? And as I said, you've done a lot of work in low and middle income countries.
Yeah, of course. And I'd also like to add one other thing to Raj's question. I think part of the challenge is measurement, even in the countries. Because if you don't have good data measuring the burden of disease, you're never going to see the DALYs or QALYs or whatever that measurement is, and it's going to give you a skewed picture. So that, particularly for low and middle income countries, will become more of an emphasis. So we all need to be advocating for better measurement and surveillance of different conditions, not just hospitalizations or deaths, but also those broader measures. Going back to Yulia's question, let's start with you give some difficult ones. So let's start with the vaccine hesitancy question, and I think there's no easy answer there. One of the things that I'm actually thinking about, and this is, as you all know, is probably an evolving topic. It's not something that we want to widely in discussion. The goal is actually to suppress these conversations. The goal is to not hear news reports about what Trump says about this or what somebody else, Wakefield or whoever, says about this. We just want it to go underground and disappear. That being said, it doesn't mean those conversations aren't being had. I think part of it is maybe we need to talk less about immunization and more about prevention and healthy aging and reframe the conversation in a different way, because we never talk about the benefits. This conversation is talking about the risks or the negative side, and when we think about communication, what we always want to do is reframe it so people are coming up with something positive. And there's challenges in doing that because that's not sexy. But the more we can get data out there about why we're actually doing this. Most people don't think about, why are we giving our influenza shot? What value does that even provide? And I think we need to work a little bit more on that and what the consequences are if you really get sick, so people start thinking about this more as a norm rather than a discussion that talks about the negatives. Then going back to your first question, I think it was about
closing the disparity, I think, between countries and whether immunization could be a tool for doing that.
And I think some of that, again, goes back to really building the value of immunization and what immunization can do as being an equalizer. One of the things that we touched on a little bit but didn't get into a whole lot of detail is the idea of immunization as a platform to deliver other health services. So it's an opportunity to have a conversation about health, and it's not just about those diseases. It's about what do you need to do for healthy living. The other thing I think that also needs to happen to build disparities is to really build up that value of vaccines amongst governments, so your health budget is increasing, because that's still problematic. There is an opportunity through the universal health coverage conversations to really bring that up to a different level. But I think we've got to stop thinking about, you know, the minuscule point-something% increases and go to something more bold. And that requires, you know, deliberate conversations with politicians, making sure that there's champions in all of the countries, and a very defined and concerted effort to
consensus building.
Yes.
You know, holistic approach.
It can be done.
Right, Rajiv. There was the question from the young medic student from the UK. You know, MSF asked Pfizer to bring down the cost of the pneumococcal vaccinations. The cost is an issue when we're talking about immunization, particularly, you know, older people. What can Big Pharma do to make sure these drugs are not expensive? Vaccinations are not expensive.
I don't work for Pfizer, and so I won't speak to that specific vaccine, but I will talk about I do know something about the topic. And so my perspective comes from having worked at the Gates Foundation negotiating the lowest possible price for vaccines for Gavi, and now I work in a company. So having said that, I think we have, as a community, made tremendous progress in enhancing access, at least at a minimum by addressing the pricing barrier to access. And Gavi gets the bulk of the credit for this, as well as PAHO, because of the pooled procurement mechanism that allows them to secure lower prices in return for committing to certain volumes, ideally for multiple years. If you look at the price curve for the pentavalent vaccine, it has almost bottomed out. The price is extraordinarily low, so low that companies, this has just happened, are pulling out of the pentavalent vaccine business. Now, I think that this effort to drive prices down is important. It needs to continue, in my opinion, only to a point. Because the danger of going too far is that you disincentivize the companies that are investing R&D dollars or euros into new vaccines to address current or emerging threats, driving them out of the business entirely. And then when we have the next new threat, we'll have fewer companies that are prepared to do that have the capability of developing the new vaccines. And so this isn't a hypothetical risk. This is actually a very real thing. And before anybody asks me, delinking the R&D from the cost of the vaccine doesn't work in all cases. It may work in some cases, the ones that I mentioned earlier. But you also have to realize that in the context of a company, and I'm going to speak generically, or any business for that matter, you have to justify any investment that you make to your board and to your shareholders. And if you have 10 different things that you can do, they each have numbers associated with them in terms of return for the shareholders. And the math is that those that have the better return and lower risk tend to do better. Now, you can allow the lower return investments to go forward to a point, but if that lower return becomes too low, it becomes really hard for people inside companies to justify these investments. I'm being quite candid here because I think that this is exactly the audience that needs to understand a little bit of the dynamic that happens inside companies. We're talking about vaccines here, but the same dynamic occurs in any company that's making any investment decisions. Pharmaceutical companies are not unique in that way. And so I do think the pricing pressure has paid huge dividends for the global health community. A lot more kids are immunized as a result of it, but the community needs to get very sophisticated in understanding what the limits are and what the potential unintended consequences could be.
Thank you. You wanted to come in briefly on this.
A very brief point. The regulatory bodies also delay new drugs being introduced because every drug has to go through so many different regulatory bodies that many companies have to give up because it's just such a long process. And in fact, the Gates Foundation funded a researcher looking at this, because if it's taken you 18 or 19 years to develop a drug, whether it's a vaccine or any other one, by the time it's gone through all the different regulatory bodies, Europe, the States, the Far East, etc., it's 21 years, and then they lose, it becomes generic. So they can't go on. So we need to speed up that process, which would help enormously in getting the drugs or the vaccines, or whatever they are, to people quicker, and therefore the price go down.
Can I also add just so you took the point to regulatory, but to take it to access takes another decade to do 2 decades, and we have done the work to look at those timelines. So job not done.
Just a minute each, finally, panel. WHO launched the Decade of Aging. I mean, perhaps just very, very quickly, all of you, what kind of outcome would you like to see at the end of that? Laurie?
I really think it's the time of opportunity. It's a great time to start a dialogue and bring in new stakeholders. It's not about the immunization community solely. This is all of our issues, and the more that we can come together and push this forward, we need to find a champion to move the adult immunization space forward now.
Thank you, Lois. Rajiv?
Well, I'm very excited, having seen what happened with the decade of vaccines, and I've been told that the two are not in any way connected, but maybe they ought to be. I think the decade of vaccines call to action has spurred many stakeholders to do things that they didn't think were possible. And as a result, I think we're in a far better place today in 2017 than we were when it was announced in 2011. So I'm very hopeful that we'll see similar progress on the aging side.
Sally?
Well, it's just a public awareness exercise that we must all be part of, I think. The aging organizations, retailers, employers, everybody, just to get the message across that if we want to be able to celebrate the aging of society, let's get this right. We've got to do everything we can to make that a good experience, not one which is actually terrible because you've got illnesses that cripple you for years before you die. Let's do everything we can so that we can really celebrate the aging of society.
Final word to you, John.
Okay, what we dream of is that everybody has the opportunity to live a long and healthy life. And what that requires is thinking of life as a continuum and making investments across the life course in a way that can enable the abilities and the capacities that we all want for older age.
Thank you very much indeed. Thank you to my panel. May I invite Thomas back onto the stage, but thank you very much, panel. Lois, thank you. Thank you. Thank you. Thank you.
Thank you very much to the panelists, I think, and to our moderator. I haven't promised too much. I talked about an eminent panel of experts. I think we got outstanding experts and also an outstanding moderator. Therefore, I'd just like to ask you, give them another big hand again. Closing this event, I would like to thank all of you for having come here and also actually to have given us food for thought, because it's obvious that aging is something which is positive. Investing in healthy and productive aging is something which we need to consider even more. It's also obvious that immunization is something which is often seen as something for children. Actually, last week I had the pleasure and privilege to be invited to Marcy, which is probably the biggest site of manufacturing research of vaccines, founded in 1917 by Mérieux and celebrating their 100th anniversary this year. I have to admit I'm more a pharma guy, therefore I was really stunned there by two things. One is to see that in terms of quality assurance, vaccines require about 50-fold manpower what you have in pharma. I couldn't believe it until I saw the numbers. And it is important because quality does matter, because in contrast to medicines where you treat sick people and occasionally you are willing to take a risk in terms of if you suffer from a deadly disease, from cancer, you're desperate. And you may, be willing to accept risks. In vaccines, you infect healthy humans, or you put a disease-carrying vector into healthy humans. And that's why quality does matter. I also believe that it is important that we do talk about cost sustainability, but I also think it's important that we talk about the value immunization brings, the value healthy and productive life years brings. I would invite all of you, please stay around, talk, have a good time. It has been a hectic and intense week, not just for our colleagues from WHO and the international organizations, for all of us. It had important conclusions. The atmosphere occasionally was animated. I think that's what you need. We also, as an industry, need to be exposed to tough questions. We need to stand up and argue the value of what we bring to society. But thanks for having come here to the IFPMA event, and thanks to the panel and all the participants. I wish you an extremely pleasant evening. Thank you.